Namaskar, Hare Krishna. I'm Dr. Manish. Today I'm here with you to discuss about the difficult case series which are of deep understanding as far as the management of the difficult critically ill patient in ICU is concerned. So in order to understand that what kind of a case we are going to have today for the dissection, for the learning and the planning, that how can you plan the care of these patients in your ICU, we have a team of the experts to discuss about this case. We have Dr. Ankit, who is working as a consultant in the Department of Intensive Care, Sharda Hospital. We have Dr. Munashira Saeed, consultant in the Department of Intensive Care, Medicine at Sharda School of Medical Science and Research. Myself, Dr. Manish, who is working as a head and consultant in the same hospital, and Dr. Muskan, who is deeply interested in sharing these learnings, and through Dr. Muskan, we are going to understand and unfold these difficult cases which otherwise serves as a deep challenge when you manage them on day to day out. So, Dr. Munashira, so let me ask you first question, what this case is about, which you feel that it has to be discussed, and what is interesting about this case? So, can you just give the brief outline about the case?
Yes, sure, sir. Hello, everyone. So, let's discuss the first case of this series as a case of difficult weaning. She is a case of 62 years female patient who was presented to our hospital with shortness of breath and excess and productive cough since 1.5 months. She was a known case of diagnosed pulmonary tuberculosis outside the hospital, for which she was taking an AKT. Now she has presented to us with increase in the shortness of breath, and she was in a condition of septic shock also, with having tachycardia, hypertension. So we have to intubate her electively for further management. Once she was intubated, we have given different trials of weaning, but the weaning was failed. So again we have to ventilate her for a long period of time. For that we have tracheostomized her after 7 days of ventilation over the endotracheal tube. Once the tracheostomy tube was put, we tried to wean off her further, but
she was not fitting,
fitting into the criteria.
If I have to reframe and paraphrase what you had said, Dr. Munashira, what I can understand, a 65 years old lady who is a known case of maybe the COPD, and she was having a progressive shortness of breath for the last 1.5 months. And she has been diagnosed as a case of pulmonary coughs, which was proven on the basis of the sputum culture and sensitivity. And basically she came to you as a respiratory failure and septic shock. You managed on the line of septic shock. You managed on the line of type 2 respiratory failure. But given the fact that septic shock was able to recover, but the patient continues to be on ventilation. And since she was failing again and again onto the spontaneous breathing trial, so we consider this patient to fall for the tracheostomy. Now, despite of having a tracheostomy for last 10 days or so, the patient still continues to require the positive pressure ventilation. We are not able to initiate the patient on spontaneous breathing trial, because the moment you put the patient on SBT, despite of the pressures which are relatively high, let's say 14/8 of pressure support, she becomes very tachypneic, she becomes tachycardic, she becomes hypertensive. So, in short, we are dealing with a case which is a prolonged weaning. Maybe the difficult weaning is heading towards the prolonged weaning. So now I need to know from Dr. Ankit, how commonly you see this kind of cases when you talk about the difficult weaning or the prolonged weanings. Also, I would like to know, what do you understand by difficult weaning, Dr. Ankit?
Usually, not in daily routine. We doesn't see.
So we don't see in daily routine.
We doesn't see these kinds of cases which require prolonged weaning or difficult weaning. In this case, she stayed in our hospital almost for 21 days.
21 days.
21 days.
Big number.
So in spite of tracheostomize this patient, still she is requiring some positive pressure ventilation support. So in this case,
what is a normal course for these kind of patients? Otherwise, let's say this is not a difficult weaning. So in your experience, because you are having a large experience in critically ill patients management, what is the standard way of coming them off from the ventilation?
They usually within a day or two, like 3 to 4 days, they usually get off from the positive pressure ventilation support.
So you initiate mechanical ventilation, you treat the disease, and then you start coming off from the ventilation.
Yes.
And by and large, 90% of the patients, they are successfully get extubated. So this was a difficult case, which means that she was not coming off from the extubation.
Yes, yes.
Because the moment we used to decrease the pressure support, the moment we used to decrease the ventilator support, she used to fail in terms of tachycardia, tachypnea, high minute ventilation.
Yes.
So all those kind of things were
Yes,
there.
yes, yes.
So how common are they? Otherwise, what is your, in your experience, how commonly you see these cases? Like 1 in 10, 1 in 5, in what proportion? Just I'm trying to understand from you.
Yeah, only out of 10, maybe 2 cases or 1 cases like this.
So maybe 1 out of
Yeah,
the 10.
yes,
So which just
exactly.
means just 10%.
Just 10% of the incidence.
So idea is that, why I'm asking this thing, because difficult weaning and prolonged weaning, they are definitely the subset of the cases
Exactly.
which comes as a weaning challenge. And by and large in the literature, the incidence is around 6 to 10%.
6 to
So our experience is almost same, right?
Yes.
So when you have this kind of a case, Dr. Ankit, how you approach them, how you manage them otherwise. So let's say that you initiated mechanical ventilation.
Yes, yes, yes.
Patient came off from the shock, septic shock. You planned the patient on SBD trial,
Yes.
spontaneous breathing trial. After giving a spontaneous awakening trial, and now the patient could not tolerate the pressure support
Pressure
trial,
support trial.
which means the patient is getting tachycardic tachypnea.
Yes.
So I want you to help us in understanding that from this step, how normally you proceed when you are failing first time onto the pressure support trial.
Yes, yes, yes. Very nice questions, Dr. Manish. Thank you. Usually we used to wean this patient after resolving septic shock, all kind of comorbidities, all kind of pathology for which patient was admitted in ICU. So after correction of all the major acute events, we used to try to wean off the patient.
Very important point. So what I can understand, Dr. Ankit, from you, that the indication for which the patient
was
was
intubated.
initiated on mechanical ventilation is the first priority to be taken care of.
Exactly.
So in this case, you are suspecting the case has a community acquired
Community
pneumonia,
acquired
which was leading to acute exacerbation
Yeah.
and septic shock.
Yes, yes, yes.
So you sorted out the septic shock.
Exactly.
You sorted out the community acquired pneumonia part.
Yes, yes, yes.
And normally we expect that once these two parts for which the patient was being initiated on mechanical ventilation has been sorted out, now they are ready to come off from the mechanical ventilation. Very nice, very nice.
So
that
that
is
the
the first
background was there. She was diagnosed as a tuberculosis. That was the primary.
So
event.
the background, she has a tuberculosis, pulmonary coughs.
Exactly. So after the stay in ICU for 7 to 10 days on mechanical ventilation endotracheal tube, first strategy, if she's not coming out of this weaning, if she's getting failed on weaning, on spontaneous breathing trial or anything like that, we used to tracheostomy, because again intubating, extubating, giving trial for extubation and failing of extubation within 24 hours or less than 24 hours. This is also a difficult challenge to
So,
extubate
Dr.
this.
Ankit, here I would like to interrupt you. I want you to be slow and I want you to be loud because I want the camera and the audio to capture it.
Okay.
Right?
So in this case, if although she is failing she is not getting fitting for the extubation trials. So in this, by chance, if you'll take a trial for extubation, because again intubating and extubating, repeating the same things, it will be a challenge for the patient.
Challenge. And it will be traumatic.
Traumatic also. So for such patient, first trial, what we used to do, this is normal trial, we used to tracheostomize the patient. So doing this tracheostomy will benefit the patient in terms of requiring the support of sedation and paralysis, reducing the.
So this is important point. What I can understand, Dr. Ankit, from you, if I have to paraphrase and rephrase it, that first you treat the primary indication for which the patient is on mechanical.
is on mechanical ventilation.
Now the question comes, let's say that we have sorted out, but now the patient cannot tolerate the pressure support trial or the weaning trial.
Yes, yes,
Now we know that the patient is going to fail, whatever could be the reason.
yes, yes.
But in order to make their journey less traumatic and less infectious and more easy to manage from the nursing care point of view, you generally plan the percutaneous tracheostomy for them,
Percutaneous
because with the PCT, the AV management become easy.
Exactly.
Right? Secondly, the chances of providing the good hygiene to the bronchial segments, the tracheal hygiene, which means the suctioning
and all.
requirement of sedation,
Yes,
and the incidence of complication which is related to the vocal cord,
Yes.
you can minimize that,
Yeah.
irrespective of whatever could be the reason for the patient to fail from the
Exactly.
ventilator.
And the requirement of drugs is also reduced.
So requirement of drugs will also go down because the translaryngeal intubation needs more sedation.
We will bypass this area, no? So directly the tracheal rings will be involved. So minimize.
No, I understand. It's a good point. Basically, you are trying to make the patient off from the support as much as possible.
as much as possible.
Whether it's a sedatives, hypnotics, or the ventilator support.
Exactly.
So percutaneous tracheostomy or the patient who are having a tracheostomy, they are better tolerated
Yes.
by the patient in comparison to the normal endotracheal intubation.
Exactly.
So that is what. So you are making their overall task easier.
Exactly.
Now this comes as a very standard protocol, so which we did in this case. But how will you approach that? Why the patient is failing in terms of weaning in this case? How will you? Well, what do you have any protocol in your mind that okay, I will first I will initiate. If it is not tolerating, I will give another second breathing trial. If it is also not tolerating, then I will plan something else for my patient. Let's say a tracheostomy, and I will do 1, 2, 3, 4, 5, 6, 7, 8 things.
Yes, yes, yes.
That will help me. That okay, all the possible corrective measures has been taken care of.
So, in case-to-case basis, so definitely, what I used to do, I give the second spontaneous breathing trial, second trial of
So second trial you
Yeah.
consider.
If we consider, sometimes we try for TPs also. Sometimes such cases.
right.
Okay, let's to see, and we should be there bedside. Whenever we are giving this any trial for this weaning trial, we should be there bedside to just to monitor how is the vitals going on in this patient, and we have to assess whatever the weaning support we are giving, is it working for the patient or is it not working for the patient. So initially we gave two to three spontaneous breathing trial. Two we responded on the first day, and another day also we tried.
So you gave two, I
Two
think
SBT
two
trials
SBT trials
in one day.
In one day,
One day.
After doing some optimization in terms of, let's say the patient given some diuretics so that the lungs which are filling up congested, at
Exactly.
least they have been taken care of. In case if the sedation was a reason for the patient to fail,
Exactly.
then you gave the second trial to the late part of the day,
Late part of the
so that the
second half.
sedation should not be the reason for the patient to fail from
Fail from
the weaning,
Yeah.
right? So these are the two important things.
Exactly.
So these are important points, Dr. Ankit. So what I'm trying to what I'm trying to emphasize in this conversation is that whenever your patient fail to the SBT trial, you must revisit again the basic things. Do I have taken care of the primary indication for which the patient is on mechanical? Let's say there's a pneumonia
Yes.
and it's a non-resolving pneumonia. There's no point of trying the patient to be on a vein because primary indication for which the patient is on ventilation is pneumonia or the septic shock. So unless and until they are better, how can you expect the patient to respond better in terms of the weaning? That is one. Secondly, what I understand, there are a lot of confounding variables.
Confounding variables.
Every patient who is on intubation protocol, they receive some sort of sedatives, hypnotics, analgesedation, which interferes in the patient neural breath trigger cycle.
Exactly.
So the sedatives, they affect your respiratory cycle, they affect your breathing pattern, they affect your triggers, they affect your volumes. So you make them off. So you are making sure that the second trial which you gave to this patient was when there was a sufficient time which has been elapsed
Yes, yes.
and the patient was free from actually the sedatives and the hypnotics. More commonly we use fentanyl in ICU. So that has been. Third, you said that you gave them some diuretics.
Yeah.
The reason why, because diastolic dysfunction or diastolic heart failure, which is now known as heart failure with preserved ejection fraction, is much more commonly seen in the elderly patients who are hypertensive, who are diabetic, who are obese. So these are the common issues which we see them. And diastolic dysfunction is exactly going to behave as if the patient is having a CHF with the systolic dysfunction.
Yes. Having said so, all this, after taking care of all the background things, because we give so much of diuretics in this, so we have to optimize all electrolytes in this.
Okay.
All because as during the course of the stay in ICU, she was growing acinobacter in the endotracheal tube, and we have done bronchoscopic lavage in this patient just to check which type of pneumonia we are dealing with. So in that sample also we saw that she was growing MDR XDR bugs, that is acinobacter was growing. So for that we have given polymyxin for this patient.
So another important thing,
Yeah.
unless and until the infection is treated, there's no fun in giving the patient a weaning cycle.
Exactly.
So when the patient was failing, the idea was to pick up whether the patient is failing because of mechanical reasons or infective reasons. And here, which I can understand from your presentation, is that the patient was failing in the initial part because of the infective issues.
Infective issues.
So once you identified the infection by doing a specific lavage sampling to the specific bronchial segment, you were able to show that we are dealing with the Acinetobacter, so it needs treatment, which you
Yes.
started. Right after starting the treatment for Acinetobacter, what was the course of the patient? Was the patient was able to get wean off? Because
No, that is the challenge we are facing.
So the
Even-
point here is that despite of treating the infection,
Yes, yes, yes.
which was initially seems to be the most plausible factor for the
exactly.
patient to wean, to fail from the weaning, despite of that treatment, the patient continues to fail. And as you said, dyselectronemia is a common reason. So I think the doctor said that's why all the patients who are in ICU they should be well managed in terms of their electrolytes profile.
Yes.
What electrolytes you normally feel, Dr. Said, they are important for the patients?
We usually check
Which
for the
helps you
serum
in the-
sodium,
sodium?
levels and serum potassium levels,
Potassium.
and serum chloride levels, and serum magnesium is also much more important. Along with that, we can check for serum phosphorus levels also.
Very good. So I think you have said all the important sodium, because sodium is responsible for your, the brain drive. Your sensorium is get affected in case. So if your sensorium is bad, you don't expect the patient to behave good. Second, as you said, potassium, magnesium, and phosphate. They are very important for muscle strength.
Yes.
So if you don't have a muscle strength, it's going to behave as if there is a pump failure. The patient will get exhausted easily.
Yes.
And when they get exhausted, they basically become type 2 respiratory failure, which serves as a reason for them to fail in terms of the breathing. So that is, so we optimize onto the electrolytes, we optimize onto the infection profile,
Infection profile.
we gave them enough trial after taking off the sedation and the diuretics, and despite of this, now the patient is stable. So what next you have done, Dr. Singh?
One more concern with her was her hemoglobin was on the lower side initially. So the hemoglobin, as we all know, it's more important for the oxygen carrying capacity of the blood. So we tried to improve her hemoglobin. After 2 blood transfusions, her hemoglobin now is 9.3, which is sufficient for her. Now again, even after that trial, we were failed to wean off her from the
So,
ventilator.
okay, now here I would like to know opinion of Dr. Ankit. So, do you regularly build up the HB to 10 gram % for your ICU patients?
Not exactly, because cutoff for transfusion in regular routine cases in ICU is about 7
7 gram %. So, but in this case specifically, as Dr. Said has said, we were trying to reach up to 10.
Yes, yes.
And the reason is because oxygen carrying capacity of the blood is directly responsible for the diaphragmatic fatigue and from shunting the metabolism from aerobic to anaerobic metabolism, which
Yes.
happens with them. So that is one thing. So it's a good indication. But at the same time, it's going to be a risk factor for TACO and TRALI, which we have to take into account. When I say TACO, it means transfusion associated circulatory overload. So that means it has to be given under the diabetic cover.
Yes, yes.
TRALI, you cannot treat it unless and until, it's where the patient will have a new onset infiltrates in the chest and they will behave like acute lung injury or ARDS. We were lucky that it was not the case of either the TACO or the TRALI, right? So what next we could have done?
Next, we were just planning because she was on polymyxins for almost over 7 to 10 days. So there's in tentative we used to call it like critical illness polyneuropathy or like difficult weaning in these cases because she was on polymyxins.
So what polymyxin we were giving in this case and what was the route of administration?
It was intravenous route only we were giving it, and
We were giving
and
intravenous.
for nebulization also we were giving because the lady was going Acinetobacter, so nebulization colistin was also we were administering to her. So maybe this is also one of the reasons for her prolonged weaning because she was on for the longer time on polymyxins, colistins.
So that is very important point, the drug use. A person who's on steroids, a person who's on polymyxin, the person who's on aminoglycosides, they become important reasons for the patient to develop muscle weakness. So critical illness myopathy, critical illness neuropathy, ICU-acquired weakness, which we call it as now. So they become the risk factors for the patient to develop all these things. So which was an important finding. So once it was taken off, then you expect the patient to recover unless and until the sepsis is persistent. So what is the current status for this case? If we really have to reach to the conclusion, then what you did?
After optimizing all the things, like after optimizing electrolytes, after optimizing
I
this
want you to
muscle
be loud,
buildup,
Dr. Ankit, because it has to be heard. In the
after optimizing all the electrolytes or muscle buildup, nutritional requirement of the patient, after taking care of all these points, we have planned why we are failing in this terms and weaning this patient.
Really?
So we have planned for after almost 10 days of 10 to 15 days stay in our ICU, we plan to go for CT scan, imaging, just to see what is the pathology or what is the concurrent pathologies going on in the chest. Because all the time patient was complaining of chest heaviness also, meantime in the stay in ICU.
So very good point.
So we planned for CT,
Excellent.
HRCT chest, high resolution CT images we have done today.
So the point which is that when the patient is failing in terms of the weaning,
Yes.
it's very important to know the status of your lungs and the status of your pump. The pump means your cardiac pump. So we have obviously assessed the patient for heart functions. Heart functions are good. NT-proBNP was not elevated. So patient was well placed in terms of the heart functions.
Yes.
Now the second thing comes the diffusion of the gases which happens across the lung. They have to be optimized. So we wanted to know that what functional status or the structural status the patient is placed in terms of the pulmonary system. So we got the CT scan done.
Yes.
So would you like to know that share what is there in the CT findings? We can focus.
Yeah.
So Dr. Ankit, would you like to take an attempt?
Yes. So this is the coronal section, and this is the CT chest of the patient.
So what specific findings you can see, Dr. Ankit?
In this, we can see the interstitial pattern of the interstitium is highly prominent in both the left side as well on the right side of the
Very nice.
chest. So interstitium is very prominent. Along with this, can you see this, as this is a diagnosed case of tuberculosis? Can you see some cavitatory lesion also in this? This is
So I think this is where you're talking about?
this one. This is the
so there is a cavity.
Cavity,
Yes, it's a
yeah.
cavitation which is there.
Yeah.
So this could be a reflection of the tuberculosis which the patient is having, right?
Exactly.
So what I can see, Dr. Ankit, what you're saying that there is an extensive interstitial pattern which you can see with extensive ground glassing, which is highly suggestive of non-specific interstitial pneumonitis.
Exactly.
NSIP pattern is basically you see in a patient, it's a type of interstitial lung disease. And you can also see the evidence of COPD, like you have, the cystic spaces which are dilated,
Yes.
and it's a honeycombing pattern in the left basal segment of the lung, which is a reflection of the COPD status.
Yes.
So a single patient who has pneumatoceles, who has honeycombing pattern, along with the extensive ground glassing, with the non-specific interstitial pneumonitis pattern, and there is a cavitation. A single patient who has COPD, who has ILD. So in short, I think it's a kind of COPD ILD overlap with acute infective complication in the form of tuberculosis, because there is a cavitation and it is proven on the basis of your AFP stain that the patient was having multibacillary COX. So this is a very important, and plus you can see an extensive consolidation and collapse in the right basal area.
Yes.
So that could be another reason, which could be a part of your acute, another contributory factor in terms of the infective issues which the patient is going through. So there is still ongoing infection, and the more vehemently which I can see in the CT findings is the presence of non-specific interstitial pneumonitis. And it appears to me that it's the ILD which is making this patient fail in terms of coming off from the ventilation. So these kind of cases, they need long-term ventilation support, and they will, maybe in some cases, they may not even fit for coming off from the ventilation. The good thing is that, if I have to show you the patient is conscious, alert, obeying, if I have to just show you the patient, if you can have. So if I have to show you, which I was discussing about the same case, Mataji, हाथ ऊपर कीजिए. अभी पहले से आराम है. नीचे कर लो हाथ. जीभ दिखाइए. So you can see that the patient is comfortable, obeying commands, having no motor deficit. The same case was there with first for almost like 21 days. So requiring only 40% of ventilation FIO to support. But the moment you try this patient on CPAP, pressure support, she starts becoming tachypnic, dyspneic, and high minute ventilation, which eventually reflects that the patient cannot tolerate the weaning care. So she has non-specific interstitial pneumonitis, which is a part of your ILD disease. And these kind of cases, they become very difficult to eventually wean them off from the mechanical ventilation. And maybe these kind of cases, they go on invasive BiPAP for domiciliary reasons, even for domiciliary. So which means you ship them to home with a BiPAP machine which is connected to the tracheostomy tube, and just to keep them on support. So these kind of cases, they never ever at times become fit to come off from the mechanical ventilation. This is what we wanted to show. But at the same time, I would like to congratulate Dr. Ankit, Dr. Munashira, Dr. Muskan, and Sandeep, who has been there working hard, along with Girish and Anil and Ravinder. If you can see, sustaining this kind of a case, who has a lot of infective complications, having a septic shock, then failing onto the weaning cycle to the extent that twice she failed, then going for a tracheostomy, and then post-tracheostomy sustaining for infective complication like Acinetobacter, not landing upon vasopressors, having a multitude of elements like dyslipidemia, persistent hypokalemia, hypophosphatemia, taking care of the heart functions, treating them on the line of a diastolic dysfunctions, and reaching to a level where now you have a CT scan and you can clearly say that it is the ILD which is leading to the failure. This is a commendable job. So I think in short, it was interstitial disease with an acute exacerbation secondary to the infective complication in the background of the COPD with a commonly acquired pneumonia with a septic shock, which describes this patient in toto that what all she has gone through. Fortunately, she has no significant component of ICU acquired weakness, criticalness, polyneuropathy or myopathy, which is a good part, and we are happy for it. And hopefully, I think Dr. Ankit, Dr. Munashira, you will be able to shift this patient to your home. Not your home, the patient. Thank you.
Thank you.